Dr. Freddie Revilla is the Chief of the Division of Neurology at Greenville Health System, a clinical professor at USC School of Medicine, Greenville campus. He's very active in the community, served as the medical director for the Tri-States Parkinson's Wellness Group, the medical advisor for the Huntington's Disease Society of America, and is a member of the Parkinson's Study Group. In 2013, he was elected as a fellow of the American Academy of Neurology and the American Neurological Association. Dr. Revilla promotes exercise in his patients and also participates in exercise himself as he climbed Mount something I can't pronounce in Bolivia and dedicated that climb to his patients with Parkinson's and Huntington's disease. So please help me welcome Dr. Freddie Revilla.
Thank you, Lauren, for the very kind introduction. It's always a pleasure for me to see so many familiar faces. So many, actually, because I recognize a lot of you here today. So I'm truly delighted. And not only am I happy because you're here, but also because part of my team is here. So I want them to stand up. So we have our nurse practitioner, nurse navigator, Yuzi and Osike here helping us. And we have Enrique Urrea Mendoza is in the back as well. He's manning the computer today. He does research with us. Dr. Vijay Kumar just joined our group a few weeks ago, coming from Baylor University in Houston, Dr. Vijay Kumar. And even Dr. Jim Davis is here working with us. Thank you for coming, Jim. He's running the Center for Successful Aging. Thank you for coming. And if anybody else joins, please let me know. And you're going to give part of the talk, by the way, so get ready. So today we're going to talk about a topic that is very dear to my heart and very important, not only in Parkinson's disease, but in general in neurological disease. It is exercise. So I'm going to ask a question. So how many of you are actively exercising now with a regular program that you have? Raise your hands. Terrific, terrific. So that means I won't ask you to raise your hands if you're not, but you see, you are inspiring us, okay? It is not easy to do exercise. We all have a hard time getting up in the morning and thinking I have to go to the gym, or I have to go walk, or I have to go run, or ride my bike, etc. So it has to be a change in mental attitude to that. But today we're going to review not only the scientific data that is out available to see why we need to exercise, but also some of the patients' experiences that I'm going to share with you today. So this is what we're going to do. So let's start with the first slide. I want to talk first briefly about the general topic of Parkinson's disease, because I'm sure there's many here who are recently diagnosed or even family members of patients who have Parkinson's disease, and you don't know much about Parkinson's. So those of you who are relatively new to the diagnosis, can you raise your hand as well? Okay, so I see many hands here. Okay, so Parkinson's disease is a neurological disease that was initially described by James Parkinson, a physician, who wrote this essay on the shaking palsy. Can you go back one slide, Enrique? The essay on the shaking palsy is the famous first publication from James Parkinson. And typically I would show the picture of the author of a book, but in his case there's no known picture of James Parkinson. That's the house where he was born in England. He described 6 patients with Parkinson, some of which he did not even examine. He saw a couple of them crossing the street. So what that tells you is that Parkinson's is a very visual disease. You can see the change in the walking pattern, you can see the tremors, maybe not in the beginning, but later in the disease. So that's how this was described. Then it took some time to recognize the condition in the books of neurology, and the picture I'm showing there right now is from a famous neurologist from France, Charcot, who actually coined the name and assigned the name of Parkinson's to the disease. So that's how we call this condition Parkinson's disease. It's one of many other neurological, neurodegenerative, progressive diseases of the brain. So there's many of these. And to make it more confusing, some of you may have heard the term Parkinson's plus syndromes. So raise your hand, whoever has heard the term Parkinson's plus syndromes. I see a few hands. This is very important to realize as well, because there's Parkinson's disease, the regular Parkinson's disease or classic Parkinson's disease, and there's the Parkinson's plus syndromes, where these are conditions where the progression of the symptoms is faster and the level of disability may be higher, unfortunately. And so it's important to make that distinction as well. And we call it Parkinson's plus because we see the symptoms of Parkinson's disease plus other neurological features. Next, please. So we're talking about this part of the brain, deep inside the brain. And unfortunately, I didn't bring a laser pointer, but Enrique, maybe you can use the arrow to point. See, the outer part of the brain is called the cortex, surrounding the whole brain. And this is a brain, imagine you're looking at my brain from my left side, and that's how it's cut there. But Enrique, move the arrow to the middle of the brain, and that's the brainstem up there. And that specific part where the arrow is hovering around is the midbrain. Just a little lower, Enrique. There you go. You have to do neuroanatomy again, by the way. So that is the midbrain. This part of the brain is called the midbrain. This is a very deep part of the brain where the actual cells that produce dopamine exist. And so I'm introducing another word here, dopamine. Dopamine is a neurotransmitter that communicates between cells. So the brain cells communicate between them by the release of neurotransmitters. And one of them, one of many, is called dopamine. And this is the part of the brain where dopamine is produced. And that's where the problem is. Next. So this is another picture where Enrique pointed the front part of the midbrain. So that is the front up there on the top, and the back part is on the bottom. So again, you have to use your imagination here. Imagine you're looking at my brain from the top like this, and in a cut of the midbrain or the brainstem. And so you can see clearly that there's a big difference between the left side in a patient with Parkinson's disease and the right side in a normal person. The main difference is that there is an area of pigmented brain cells that is called the substantia nigra. And substantia nigra means black substance because these neurons have this black pigment in it. You can clearly see that it has disappeared in the patient with Parkinson's disease compared to a normal person. So the message is that in this very deep part of the brain, there are these cells that produce dopamine that starts suffering dysfunction first, and then they start to disappear one by one, thus producing a lower level of dopamine compared to normal people. And that is one of the main problems. Now, this is not the unique phenomenon in Parkinson's. There are others that occur in simultaneous fashion and other parts of the brain, but this is the main part of the brain that is affected. And remember that the lack of dopamine is one of the main problems in Parkinson's disease. Next, please. My patients ask me, doctor, are you sure that I have Parkinson's disease? And my answer is always, no, I'm not sure. I mean, it's a very humble situation because the truth is we don't have a diagnostic test for Parkinson's. Research is ongoing to find one, but we don't have one yet. So the only way to diagnose Parkinson's disease with certainty is by looking at the brain under the microscope, like I'm showing in this picture, where you see these round inclusions inside the cell. So this is a cell inside the midbrain that is showing these three round inclusions, these three little circular structures that should not be there. And those are the famous Lewy bodies. I'm sure you've heard Lewy bodies before. So Dr. Lewy is a famous neurologist who described these Lewy bodies in the brains of patients with Parkinson's disease. Those inclusions should not be there. The real question, and I think it will be a second Nobel Prize for Parkinson's if somebody finds the answer, is why are these Lewy bodies there? Why are they forming, and what is really causing the problems in the cell? But that is unknown at this point. The first Nobel Prize related to Parkinson's disease was given to the scientist from Sweden, Arvid Carlsson, who discovered the role of dopamine in Parkinson's. The next question is, why are these cells not functioning properly in Parkinson's patients? And we don't know the answer to that, by the way. Next. Now, I said there's no diagnostic test, but at the same time, I have to also admit that there is a test called positron emission tomography, and there's another test called DAT scan, by the way, and some of you may have even had DAT scans in the past, that can show some degree of abnormality in this part of the brain. The reason I'm saying it's not diagnostic is because all these tests can tell us is if there is a normal brain versus an abnormal brain. Now, most of the time when you get to the neurologist and we do an examination and you provide the history of your symptoms, we can tell that there is a neurological disease. So this is why the test confirms that, but doesn't really help us differentiate between Parkinson's disease and one of the Parkinson's plus syndromes, which is what we really need. But anyway, this is just to show you, in case you wonder, that there are some tests available to look at this deep part of the brain with radioactive substances, and this is how they look. Next. So Parkinson's is a visual disease, as I said. Some famous people who have or had Parkinson's have increased awareness of the disease. And here I'm showing pictures of Muhammad Ali, who died after more than 30 years with Parkinson's. Janet Reno and Michael J. Fox as well had Parkinson's. John Paul II had Parkinson's as well. And they have been major advocates for research, and especially Michael J. Fox, as you know, has a foundation and is promoting research. Now, we know a lot about Parkinson's disease thanks to the research, but there's a lot to still learn. Next. And there's even a classification of Parkinson's in stages. I don't want you to focus too much on this because the truth is, even if you think about patients with Parkinson's who have had it for decades, 20 or 30 years or even longer, the medication still has an effect. It's just that the medication effect is very brief and the patients wear off. But this classification was established before medication was available. Levodopa became available more than 40 years ago, but before then there was a study at Columbia University in New York where this classification was established. And we go by Hoehn-Yahr stages 1 through 5. So 1 means that the symptoms are in one side of the body, which reminds me to tell you that typically Parkinson starts with tremor in one side, one hand. Moving to stage 2 where the symptoms become bilateral. Moving to stage 3 where there is a problem with balance and patients may start falling, and that is of course a dangerous situation. Stage 4 when patients require help with ambulation, and finally stage 5 where patients are not able to walk. However, let me make the disclaimer again that the majority of patients, even if they're in stage 5 after taking the medication, they are able to walk even with a walker, etc. So this classification was established before the use of the medication, which is a completely different situation. Next, please. And so the next slide is a busy slide, but just to tell you that there are, luckily, unfortunately for all of us in this room, many medications available to treat Parkinson's, many. And the main medication is called levodopa. It's part of carbidopa, levodopa. So it's always hard to pronounce that medication name for the first time and hard to remember, but carbidopa, levodopa is just the name for a medication also called a Sinemet. And levodopa is the active part of the medication, and levodopa turns into dopamine. So that is the first message. So I want to make sure everybody understands in this room that there are things we can do about Parkinson's disease. The first one is medication treatment with levodopa, which is Sinemet, which turns into dopamine. It's the only medication in this list that turns into dopamine, which is what patients need. And then other treatment modalities, including exercise, which is where we're going to get soon. Next, please. And this is just to show that the introduction of levodopa dramatically changed the therapeutic strategy for the treatment of Parkinson's disease more than 40 years ago. And even continuous infusion of levodopa has been attempted in scientific studies. Next. It is such a great medication that scientists in Europe thought of a way to deliver the medication in a continuous fashion through a feeding tube. So I don't know if anybody in the room has heard or even has this treatment called Duopa. Raise your hand if you've ever heard of it, Duopa. Okay, so Stan has heard of it, great. So this is a treatment modality that involves placing a feeding tube, believe it or not, connected to a pump that goes in your belt, almost like a big cell phone or Palm Pilot, if you're familiar with Palm Pilots. And it infuses the medication continuously throughout the day, thus preventing the ups and downs. So it is a great treatment, and now it's available here in Greenville as well. We've done the procedure, I think, in 3 patients now, UC. Okay. And it was just FDA approved last year. In my former institution, I was able to treat 11 of these patients as part of the research trial, which led to FDA approval. But it is a great new treatment. But again, it's coming back to levodopa. It's the same levodopa, only being infused through a constant fashion through a pump. Next. And this graph, Enrique, if you can put the arrow on the top graph, shows the epidemiology of Parkinson's and the mortality in Parkinson's patients before the use of levodopa and below after the use of levodopa. If you can move the arrow to the graph in the bottom, right. So all the message here is that the 2 lines are separated on the upper graph, meaning patients with Parkinson's before the use of levodopa more than 40 years ago had major problems with the disease. And since levodopa became available, the mortality has been the same as the general population. So one of the messages for my patients is that Parkinson's does not shorten people's lives, and that is important to realize and embark on the treatment modalities. Next, please. And this is just a list of some of the problems that can occur with the treatment, because people ask me, well, if there's such a great treatment, then why is the need for other treatment modalities and even surgery? Well, after taking the medication for a few months or years, or in some patients more than 10 years, there's a number of complications that occur as part of the process of taking the medications, and they're listed here. So one of them is wearing off unpredictable on-off phenomena. And on the lower left, dyskinesias, which means involuntary movement, such as Michael J. Fox. And I do have some videos that show patients with dyskinesias. And on the right side, you can see that there can be mental status changes or symptoms, including confusion, hallucinations, and frank psychosis. So this is all important to realize that Parkinson's can cause symptoms that are not only related to movement, but also to the mental aspect of things. Next, please. Now, when these problems become too severe with the medication and the disease continues to advance and there's no solution to these problems, then we consider the surgical option. And this type of surgeries historically can be classified as lesional procedures and deep brain stimulation. So lesional procedure just means burning a hole inside the brain, believe it or not, as bad as that sounds. It was discovered many decades ago that creating a lesion inside the brain in a specific part of the brain could help with tremors and even with Parkinson's disease. And deep brain stimulation is a procedure that was developed in France in the so-called Silicon Valley in Grenoble, France, if anybody has been there, close to the Alps, where the automotive industry is very advanced. And so one of the French neurosurgeons in the late 80s, early 90s, decided to, he had a friend who worked in the automobile industry and got one of those big robots, if you're familiar with those big robots, the high precision robots that are used to build cars. He took that into the operating room and had a very high precision instrument to put electrodes, basically wires, inside the brain of patients. And this neurosurgeon started doing a procedure called deep brain stimulation, where these electrodes are placed inside the brain. And in the next slide, this is just to show the brain and the multiple areas of the brain where procedures have been attempted. Next. And here's the deep brain stimulation system, where it's literally a wire connected to a brain pacemaker or a pulse generator that applies high-frequency stimulation to these deeper parts of the brain. And so he discovered that he could get the same effects as creating a lesion. So since deep brain stimulation is available, then we don't have to really burn lesions in the brains of patients. We just put these electrodes and apply the electricity controlled by devices from outside the skin. So I'm not going to ask you to raise your hand if you have a DBS system, but I'm sure there's several here. And so the point is that you cannot tell because everything is inside the body and the wires are connected under the skin to the pulse generator as well. Now, if anyone wants to volunteer that at the end of the talk, please do so, because that is one of the major advances in the technology of treating Parkinson's disease has been the development of deep brain stimulation in France, and luckily it came to the US in the mid-90s. And I remember I was doing my fellowship training at Washington University in St. Louis, and my mentor looked at the data. We reviewed it in a journal. He said, no, this is a lie. It's impossible that you can get so much benefit with just this, applying this electrical stimulation. And then I remember the data was presented in a meeting in Spain in 94, 95, and then in the US we started doing this in the mid-90s, and it is real. It is very real. So it is the major development in treatment of Parkinson's after the development of levodopa treatment. Next, please. And so this is just some pictures to show you how the tip of the electrode looks, and in the operating room, those are placed in the brain. Continue. And this is just to show, Enrique, this is a cartoon depiction of the brain. And if you can point at the thalamus is where the arrow is now, then the subthalamic nucleus is that light blue area, which is very small, the size of a peanut pretty much. And then there's the GPI or globus pallidus in light pink, a little bit towards the right side of the subthalamic nucleus right there. Okay, there's gonna be a quiz at the end about this, by the way, so memorize this, especially for my team, right? So anyway, these are deep targets in the brain is the message. And again, remember the subthalamic nucleus, Enrique, if you can put the arrow again on the subthalamic nucleus, which is the most popular target for DBS, is the size of a peanut. And the electrode has to be placed exactly there. So even misplacement of 1 or 2 millimeters could result in either side effects or lack of benefit. So this has to be done with precise methods. Next. Well, but this is just to show you again that there are phenomena in the body as we are moving and walking, etc., that in Parkinson's are affected, and you can bypass the circuit. Now, this is puzzling, right? So how come this patient is completely frozen, and then by kicking this ball, he's able to walk? Well, I don't have a good answer for you other than saying that he's activating a different pathway in his brain. So that's one of the things I tell my patients, because, well, I cannot exercise because I cannot do anything. Well, let's think about a different pathway to use. And I have some examples of that as well. I had another patient, actually a patient of Dr. Stanley Fan at Columbia University who used, do you know what yaks balls are? Girls play with these yaks and these little rubber balls. Okay, he got a yaks ball, right, and so yaks. Okay, so he would bounce it on the floor. See, he could not walk, okay, period. But he got that little ball and bounced it, and then the need to catch the ball again would make him take a step, and so he could do this. So that is an amazing video that I'm probably going to show in my next talk because I have it somewhere. And there's other strategies. So some of my patients said, well, I can walk as long as there's a pattern on the ground, tiles or lines. I'm sure some people are nodding, so you have discovered that as well. So this is a scientist from Israel, from the Technion, which is like the MIT here in Haifa in Israel, who came to work in my former institution in Cincinnati for a whole sabbatical year with us. And he developed this technique of using goggles. Next. So our patients would use these Star Wars modern-looking goggles to walk, and what they would see through the goggles is a pattern of tiles. Even if they went to the mall and there's no tiles, but with the goggles they could see the tiles there and they would be able to step on them. So next. So there are, this is just to show the data. Next. That's a different modality to break the freezing of gait as well. And by the way, those goggles are being sold somewhere, and even in different countries right now, but this is a strategy as well to break the freezing. Other people use, in the time of Walkmans, and now I guess you can do it with your iPhone and play music, marching bands. So if the patient is freezing, they listen to a marching band rhythm, and then you march to the sound, and that can break the freezing of gait as well. Play this one, Enrique, please. So this is a videotape from a patient in Europe, and this is available, by the way, publicly in YouTube as well. But this is a patient that is showing severe freezing of gait, and you can see the examiner is putting her foot in front of the patient. And again, that is the visual cue, so the patient can see the foot in front and step over the foot. But still, the freezing is very severe, as you can see, to the point that a lot of my patients report falls from freezing. So falls in Parkinson's can occur for mostly two reasons. One is freezing, and the second one is true loss of balance. But here, the patient is not necessarily suffering from loss of balance. The patient is suffering from severe freezing of gait or motor blocks. So this circuit in the brain that takes care of this is affected by Parkinson's. However, another circuit in the brain is working properly. So you could almost question if this is the same person, right? But again, we've seen this in our patients as well. We see it all the time. Some of you are nodding again, meaning that you probably have experienced this, which means you can activate some circuits in the brain, but not others. And I'm not suggesting that you do this, of course, especially if you went into the street right there. But you have to, the way to approach this is go to a physical therapist, to a professional who can evaluate the patient properly and determine what type of exercise can be done safely and what type of exercise is dangerous. So by no means would I send this patient to ride in the streets, but clearly he's proving that he can do exercise on a stationary bike, for example. And then as soon as he gets out, he freezes again. I've had some of my patients report to me, they're in a nursing home, for example, that they tell me that the staff thinks they are faking it because they cannot believe that you can walk fine one moment and then freeze the other, and they need a wheelchair, for example. Next. And this is just to show that this is what happens with the response to the medication. Just not to go into too much detail, but just focus on the red graph. It's up and down between off and on, meaning when the patients are on, either due to the medication or the deep brain stimulation, patients feel very well and do well. When the patients wear off, that is a problem, and the symptoms appear. So many people have given thought to this and how to improve it. This is just a list, not a complete list of different Parkinson's organizations, including Michael J. Fox, Parkinson's Action Network, etc. So many organizations that advocate for research in Parkinson's. Next. Parkinson's Study Group is a group where scientists from all over the country and other countries in the world as well, we meet every year and try to come up with new ideas for clinical trials. Next. Michael J. Fox Foundation, of course. Next. Davis Feeney. So who here attended the Davis Feeney event? It must have been 3 years ago, more or less. Okay, great. So you know about Davis. So Davis Feeney is a professional cyclist who developed Parkinson's in his late 40s. He thought it was due to a major bike crash that he had in the Tour de France, because he's the winningest cyclist in the US, by the way. And he was the first American to win a stage in the Tour de France, and he developed Parkinson's. So he came to Cincinnati in 2003, I believe, or 2004. And to this day, there is a Sunflower Revolution event that takes place there. And then he started the Davis Feeney Foundation. And the event that he had here in Greenville 3 years ago was part of the Davis Feeney Foundation awareness effort. And he promotes exercise. So he's got to a point where he not only requires medication, but also deep brain stimulation. And he's an advocate for that treatment as well. But he's been an inspiration to all of us, really. Next. And this is the famous sunflower fields in those of you who like cycling. I'm sure there's many of you who also are aware that George Incapi lives here. And this is a cycling community here in Greenville. This is from the Tour de France, a picture of Davis Feeney riding in the Tour de France. Next. And the reason we call the Sunflower Revolution event is because of the fields of sunflowers in France. Next. And by the way, go back a little bit. So Davis Feeney has done a terrific job in joining fellow patients in this fight. And here you can see he's working with patients like the one on the right, on the left side of the picture, in promoting awareness and exercise in Parkinson's. Next. And this is a very nice picture taken in Cincinnati of Davis. And even the creator of Google, next, Sergey Brin, who some of you may know as well, came up with some funds for research a few years ago and has done many advances in Parkinson's as well. There's a website called PD Trials where you can also look at studies available to participate. Next. And this is a very key point that I want to mention regarding exercise, okay? If you can remember this point, not the whole slide, but the point. Exercise, when I was doing my medical student training and even residency training, some of my teachers and mentors did not believe in physical therapy or exercise because they didn't understand it. And then once you think about it, it's not only the benefit you get for your muscles or the range of motion or general health and well-being. There seems to be a change in the brain with exercise. And this is the main message of today's talk, is that with exercise, there is a change in your brain, a major change in your brain. And people are not aware of that. And the change is that the cells in the brain decrease in Parkinson's. And focus on this, Enrique, you can put the arrow in this sentence. There is a loss, actually the title is cut off, but basically the title of the study is that there is a loss of growth factor signaling. So there is a loss of growth factor signaling that may lead to increased susceptibility of dopamine cells to age-related degeneration as in Parkinson's. So to translate this to English, or Spanish in my case, this would mean that in Parkinson's, and the general process of aging, by the way, we suffer the loss of these growth factors. And they are called brain-derived growth factor, BDNF, and other fancy names that, again, my team has to remember, of course. But these growth factors in the brain are substances or proteins that are required for the brains, for the brain cells to be in a happy environment and grow and prosper. Whenever there's not enough growth factors, then the cells suffer malfunction and then die. So doing exercise increases the amount of these growth factors in the brain. The discovery of these growth factors in the brain also led to a Nobel Prize in a scientist called Rita Levi-Montalcini many decades ago. So this is a major discovery. So I wish I could go back to my residency time and tell my mentors that exercise is not only good because of your muscles or your heart, it's also good because it increases the amount of these growth factors in the brain, thus slowing the progression of neurological disease, and that has been proven in Parkinson's. Next. And so in early Parkinson's, you can see no fluctuations. So again, off and on, meaning on, patient is doing very well. Next. With late Parkinson's or advanced Parkinson's, you see this up and down pattern going on and off. Next. And the yellow stars represent the dyskinesias or side effects. Next. And the goal of the treatment is to create a new line, like that green line, where there's less fluctuations. And again, we said there is medication that can help with that. There is surgery that can help with that. There is the duopa or the feeding tube with the levodopa gel that can help with that. And then the goal is also to do exercise as part of this to create that new state. Next. So here's some evidence from animal models, neuroplasticity. Again, I don't expect you to go through all of these slides in detail, but can you go back, please? I think you skipped that one too fast. So there's neuroplasticity, which means induction of cell survival and cell growth, augmentation of cellular function. Neuroplasticity means that the brain is an active part of our body. Even though cells are not necessarily regenerating, they're making connections. So if any of us in this room learns to play a new instrument or starts doing a new sport, you are creating new connections in your brain. So we advise our patients to do that. And it's very important to realize that learning new things will create new connections in the brain. So this is what neuroplasticity means. Next. And so there's been experiments in animal models of treadmill running. Believe it or not, you can put a little mouse in a treadmill. So that's what scientists do. Next. And then you can also put a little mouse, they kind of tied up one of the limbs. And so they're forcing them to use the other one. So this is coming from the stroke. Next. From the stroke literature, that if somebody with a stroke has weakness in let's say, unfortunately, somebody has a stroke and has weakness on the left arm, well, the idea is the patient will start favoring the good arm. The idea is no, stop using the good arm and try to force yourself to use the bad arm so you generate that function. So forced exercise, in other words. Next. I'm sorry, this one is just to show that the neuron size, the area, and the speed number improve, and there's different changes in the brain that occur with exercise. Next. Increases cerebral blood flow, suppresses oxidative stress, regulates the expression of survival factors, as we said before, increases several neurotransmitter, etc. So bottom line at the bottom, in red, healthy, efficient brains have greater recovery and are more resistant to stress and toxins and do more with less. So this is what exercise does in the brain. Next. In Parkinson's preclinical phase, we talk about neuroprotection, so increased overall levels of dopamine, increased neurotropic factor expression, sorry for the spelling error there, reduce oxidative stress, in PD early phase, neuro repair. So look at the difference, neuroprotection versus neuro repair. So anybody who hasn't developed Parkinson's yet, and if we live long enough, we probably will develop, all of us, some type of neurological disease, but you can do exercise to prevent, okay, to neuroprotection. Neuro repair is once there's some symptoms ongoing, you can do exercise to try to repair those circuits. And there's increased localized release of dopamine, downregulation of dopamine transporters, and more D2 receptors in the brain. Next. Again, the famous word of the growth factors or neurotropic factors that are proteins that support the survival, growth, and the function of neurons. That's very important. And there's the names of a couple of them, GDNF and BDNF. And I mentioned about the forced limb use and the treadmill training, which are the studies that have been done in animal models. Next. And so in this graph, let's stop here for a minute. Enrique, can you put the arrow starting on neuroprotection? So this is one way to think of this. On the y-axis on the left side, it says percentage of dopamine neurons, right? So when the dopamine neurons are close to 100%, and you start the graph on that top part, and then time runs this way in years, exercise will help in this preclinical phase of Parkinson's, meaning if any of us is currently normal, is going to develop Parkinson's in 10 years, we are in that phase already, because the number of cells may already be dying, up to 80% of them before we show any symptoms. So this is why we also encourage everybody, even if you don't have any neurological disease, to do exercise. And this is my best excuse actually to go out and play tennis and do soccer and play all kinds of sports, because exercise is recommended for everybody. And that's what you're doing. You're doing neuroprotection to your brain cells. The next phase, once the symptoms start, and unfortunately there's already advancement of the condition, you're doing neuro repair. And then the latter part, adaptation, meaning those patients I showed with severe freezing of gait can adapt to different modalities of exercise to a different lifestyle, right? Next. The next few slides are just a number of studies just to show you the amount of science that has been done in this field. So I'm not going to stop in each one of these slides because they're too lengthy, but this is just to show you, again, going back to my times as a resident and a fellow many years ago, where there was no data on this, and now there's a wealth of data proving that exercise helps the brain in these many ways. Go ahead and move forward. And we can skip through these one by one just to show that there are all these studies, and if anybody is interested in talking about this later, we can. This one is cycling for freezing of gait. So patients with freezing of gait have been subjected to cycling experiments as well. And cycling seems to be less affected than walking when used as a physical rehabilitation method for patients with freezing of gait. So patients who have severe freezing of gait, as I showed earlier, can do cycling in a stationary bike. Next. This is another study. You can see on the right side that there is a tandem bike. Actually, I recently tried tandem biking, and it was very fun to do. So tandem biking is a very good option because you can put the patient with Parkinson's in the back, and the spouse, friend, anybody who wants to ride on the front. And this pretty much forces the patient with Parkinson's in the back to pedal. Right? And believe it or not, there was a study done in Cleveland. It showed a major improvement, and this has many, not only the health consequences of this, but the brain changes and doing the exercise to the tandem biking. So there's been studies on this. And here locally, we're planning a study on tandem biking. Next. You can skip this one. It's about the same. So vigorous exercise and Parkinson's, ongoing structured progressive training is highly encouraged, particularly for deconditioned patients with PD. And levodopa and other forms of dopamine therapy should be used to maximize an individual's participation and motivation. So it's a combination of medication, your doctor, your trainer, your physical therapist, occupational therapist, etc. Next. Now, there are barriers to this. Again, as I said earlier, not everybody likes to do exercise, right? And it's hard to do. So these are some of the problems. Low self-efficacy, low outcome expectations, it won't work. Fear of falling, of course, that's valid. Lack of time, we all say that. The level of education, the lack of support provided by healthcare professionals and organizations. Okay, I want to do exercise, but where do I go? One of my patients today, before coming here, that's the reason I was late, by the way, was telling me that he wants to participate in a boxing program for Parkinson's, but it is expensive and it's not covered by insurance, so that's a limitation because it's not readily available. I'm sure many of you are participating in the boxing for Parkinson's program here, but it is not easily accessible either. Next. This is another paper just showing the effects of exercise. Next. Another one. Next. Next. Skip this one as well. You can skip this one as well. And these are, we're getting to the end of the talk where I want to emphasize some of these benefits. So possible benefits of exercise, prevention of cardiovascular complications, arrest of osteoporosis, stronger bones, improved cognitive function, prevention of depression, improved sleep, decreased constipation, decreased fatigue, improved functional motor performance, improved drug efficacy, optimization of the dopaminergic system. So it is very difficult to argue against exercise, but you have to do it safely too, by the way. The last thing we want is to see a patient fall, for example, or injure themselves. Next. And this is a picture of Davis Feeney on the right with his son, Taylor Feeney, who is also a cycling champion as well. So this must run in the genes. This reminds me to tell you that Parkinson's disease, for the most part, is not genetic, because Taylor has been asking me and others if he will have Parkinson's. He's young. Only 5% of Parkinson's patients have genetic form of Parkinson's disease. So 95% are non-genetic, okay? But this is a guy who has inspired not only patients, but also researchers and physicians to start cycling. Actually, I was not a cyclist before he came to Cincinnati, but my boss told me, okay, well, next month you have to ride, I think it was 60 miles, 100K. Because you're the director of the Parkinson Center and Davis Feeney is coming into town. You have to pick him from the airport and the next day you have to ride with him. So I said, okay, I took my mountain bike and I rode 60 miles in a mountain bike. When I got to the place, everybody had left and the whole party was over. So, but the next year, then I did it for 11 years in a row. So I trained and rode with Davis. And so this is what you need to do. You need to find somebody who will go with you, who will do exercise with you in the gym, at home, wherever you want to do exercise. And that's one of the important topics we've discussed with Enrique and one of our scientists at GHS. How do we involve the caregivers in the exercise? Next. And so this is just an example that in the last year Polo Classic event, this is Dr. Jennifer Trill in the back, and we participated in a fundraising event for Parkinson's research. Next. And what you're going to start going through this. These are very beautiful pictures that we took the other day with Enrique at the YMCA. And you can keep going through this just to show how our local YMCA offers these programs of power and even cycling. So the exercise that our patients with Parkinson's, this was Monday, right? Leslie's here. Leslie Knox, raise your hand. So stand up, please, Leslie. Okay, Leslie Knox runs a program at the YMCA, and we can talk to her after the talk as well. It is a terrific program where there's this cycling program for Parkinson's and power training and other things. This is not easy. We watched them cycle for 45 minutes. And one of my patients last week was telling me that, oh, doctor, my main complaint is that I cannot cycle 100 miles anymore. I'm only cycling 40 miles. And I was like, I wish I could cycle, that amount. But so everything is relative. But right now in Greenville at the YMCA, 4 locations, I believe it is, you have access to these programs for Parkinson's. And the reason I'm highlighting this program is because the trainer is very much aware of the problems that could occur, and so nobody falls, and it's safely done. Next. And this is just to go back to the exercise study where there's a tandem bike on the top and a single person bike on the bottom. Next. And this is just, play the videos one by one and keep going through them. This is just to show you a very creative way. So this is a patient with Parkinson's disease who I took care of in Cincinnati who was in a wheelchair, very impaired, and then ended up having an optimization of his medication, deep brain stimulation. And we had an exercise physiologist, Brian Terpstra, depicted on the right side of the video, who came up with a very creative exercise program. Now, I'm not encouraging anybody to do this because this is very dangerous. Look where he's standing. And Leslie's probably getting a little nervous looking at this because this is not the standard treatment or recommended. I'm just showing you that some exercise physiologists, personal trainers, physical therapists have come up with different programs, creative programs. Next one. To applying very impaired Parkinson's patients and improve balance, for example, and different activities. So Brian invited me this a few years ago. I went to the gym and he said, bring your shorts and sneakers, and I did. And believe it or not, I could not do some of these exercises because I stood up in this thing and they threw a lot of balls to me, and it's very difficult to stay upright. This one is another exercise that was very creative. Look where the patient is standing. Remember, this is a patient who was pretty much wheelchair bound in the past. But he's progressed to this point. This tube has water inside. So if you move the tube to one side, it will be heavier on that side. And the patient was able to do bench presses and different exercises. Well, I could not do this because standing on that ball is very difficult, and having the water tilt from one side to the other makes it even more difficult. So this next one, this just shows you that the potential to improve and use different circuits in the brain is there. And as long as you deal with somebody who knows what they're doing and you do it safely, you can make dramatic improvement in the symptoms. There's no question about that. So it's not next. Not only medication, keep going. Medication, surgery, but also exercise and a change in the lifestyle. Next. And these are just beautiful pictures that we took on Monday of. Now, the other question we get is what kind of exercise? There's aerobic exercise, strength training, stretching, yoga, Pilates, different modalities. Research is not conclusive on what type, mode, duration, or intensity of exercise, but that is needed to be met in order to achieve some of these possible benefits. So this is what we're lacking. And yesterday or the day before, if you listen to NPR in the mornings, there was a scientist talking about exercise prescriptions. So scientists are also talking about, you come to my office and I give you the prescriptions for the medications, and maybe in the future, we're not doing this now, but this is a thought, we can give you, do this exercise for this long, so many times per week, etc. We don't have that yet. Next. And we're going to go through this really quickly just to make you aware that Dr. Jennifer Trill is a scientist at Greenville Health System. She works at Memorial Hospital, and she has a laboratory for exercise physiology. And keep going through this, but look at this incredible research she's doing using tandem bikes and virtual systems to help patients, in this case with a spinal cord injury, cycle. Keep going. The community-based virtual reality training, all related to cycling. Keep going. And keep going. As you know, the Paralympic team, national, has kind of the base here at Greenville thanks to this laboratory. And famous cyclists, including George Incapi and even Lance Armstrong was here visiting this lab last year or two years ago, because they can measure all these physiologic measures, and the research is really world-class. So we're partnering with Dr. Trill to study tandem cycling in patients with Parkinson's and caregivers. That hasn't been done yet. So we want to see the effect of tandem cycling in the lab with virtual reality, with the caregiver involved, to see if that will allow the couple to continue exercising afterwards and not just drop the exercise. Next. So we're getting to the end of the talk, take-home messages. Exercise may have a neuroprotective effect in Parkinson's. I think it does. Timing matters. Earlier is better than later. Inactivity is pro-degenerative. It causes disease. Being inactive causes disease. Next. Exercise is an important management tool that addresses limitations in this population. Early intervention, early referral is necessary. Inactivity is pro-degenerative. Neurologist advice is important. Again, forced use, rate of exercise may be important for PD, motor symptoms management, and medications are important to maximize participation. Some of my patients don't want to take medications, and then they won't improve enough to do their exercise. Actually, that's one of the measures of optimization of treatment. When our patients come and we say, how are you doing? And they say, very well, then we shift focus completely. Okay, let's talk about exercise. And you have to become the best athlete that you could ever be. Continuous threshold of exercise to sustain, barriers, exercise engagement to be addressed, so we need to address those barriers, of course. And barriers to exercise engagement need to be looked at within social and cultural context. Next. Further research in this area is required to determine optimal exercise dose. As I said earlier, comparative studies to determine best approach, understand underlying mechanisms, potential benefits on non-motor symptoms like depression, memory problems, etc. Innovative approaches to empower people and help them to engage in regular exercise, as they are doing at the YMCA and other programs around the country. Next. And so finally, I want to thank our own patients with Parkinson's who truly inspired us on Monday by all the exercises they were doing, and inspire me on a daily basis because I witnessed their fight, and we're here to support you 100%, of course. I went over just a couple of minutes, and thank you very much for your attention. I really appreciate you coming here.